I meet Dr. Brown at the National Institutes of Health, just outside of Washington, D.C. It's one of the world's foremost medical research centers.
So, Jeremy, I loved your book, but as a subject matter, it's kind of weird. I mean, we'll be honest here, right? Like, I can't see myself saying, I'm going to write a book about influenza and go pitch it, sell it, and people are going to love it, you know? Was it a hard sell for you? I mean, when you went to try and get this published and created, did people say, huh?
Well, I guess every author loves the subject that they're writing about and thinks, why wouldn't the whole world like to read about this? But I had been interested in influenza for a long time as an emergency physician, and like any emergency physician practicing in busy hospitals, I'd seen dozens, probably hundreds of cases of it over the years. And it occurred to me as we were approaching the anniversary of the great flu epidemic of 1918, we were 100 years away from that, it occurred to me that there was something here, a story that really needed to be told, which was not the ordinary story of what is flu, what happened 100 years ago, but really the question of how we've been grappling with this disease in the 100 years since the great flu epidemic. And so when the anniversary came along, in my mind, I said, well, this could make a very interesting book, and wrote a couple of chapters, pitched it, and actually we found a publisher very quickly, so I suppose the publisher also thought that this was a good subject matter.
You start the book in such an amazing way, telling this story about this woman and just this fight to survive, and it's influenza. And most of us, I think of it as a nuisance. You know, it's like a cold, the flu, it's not that big a deal. But it is a big deal. And this isn't 1918 that you're talking about. This is a woman, and it's 2013. Tell her story.
Sure. So it's interesting that when I was thinking about how to start the book, I was a little concerned that if we tell a very dramatic story, we will be telling something, a part of the story of flu that isn't really representative. Because as you say, the flu for most of us is a mild nuisance. But here's the paradox with influenza. It's both a mild nuisance and a killer disease. And short of it killing you, Autumn's story is really about as far as you can go in grappling this disease and coming close to death. So Autumn Redinger, back in 2013, a mother of two, going about her daily business over Christmas time, went out for dinner one evening, didn't feel so well, but went out for dinner, came home, starts texting her friend who she'd had dinner with, and the friend realizes that her texts are all garbled, and he gets worried. He comes over and he finds her just odd and really not making a whole lot of sense. They find some childcare for her two children. They take her to the hospital, and she rapidly gets worse. They actually did a rapid flu test there that was negative. They didn't think she had the flu, but even though her labs were basically okay, and the ER did a chest x-ray, looked okay, something was wrong. They admitted her, they gave her some antibiotics out of what we call an abundance of caution. But by the morning, she was so much sicker that she needed a breathing tube to be inserted. They had to medevac her to another hospital where she remained literally at death's door for some time. And it turned out that she had contracted influenza. And in a matter of hours, it had brought her from a healthy person eating dinner with a friend to somebody who was on life support. She was flown to Pittsburgh, to a hospital there, where they put on something called ECMO, which is essentially a heart-lung machine. This machine does the work of our lungs and our heart. The influenza virus had not only gone into her lungs, which is a very common pattern, that's why we cough and bring up sputum when we have the flu, but the virus had actually gotten into her heart as well and stunned her heart. So her heart was not squeezing properly, pumping blood, her lungs were not working, and we have these miracles in modern medicine called these heart-lung bypass machines. She was put on one of those for several weeks and eventually pulled through. But it was touch and go the whole time. And Autumn's story really represents, I think, that other side of the flu story, which is, yes, it's a mild disease for most of us, but when it strikes, it can take you to death's door and sometimes can even kill you.
And it's interesting because I think what I love about you and writing this is you're going at this from a number of different perspectives. You're a writer, you're telling a dramatic story, but you're also a doctor. Did you put yourself in the shoes of that doctor in the ER? Because you've worked in an ER. I mean, you've probably seen patients come in and you've probably been flummoxed and to think it's the flu and that the test didn't work the first time. I mean, as a physician, how did you How did you approach the story, and how did it affect you?
Yes. It's interesting. So I've worked in emergency medicine for 20 years, and I like to think that it's actually pretty easy to be an okay emergency doctor, but it's really hard to be a really good one. And there is so much that we need to think about. We do not have the ability of seeing patients who have been previously tested for all kinds of things, and finally, when we discover what's wrong with them, we send them to the one person who specializes in their disease. We see all comers. We see patients who really we have no idea what's going on. And most of the time, when we diagnose a patient with influenza, we're going to be right. We're going to think that the patient is going to be fine based on our tests, and we're nearly always correct. But again, the thing about the flu is that it does have this ability to go bad very quickly, and we don't want to scare our patients. We don't want to tell them that flu is a potentially lethal disease, although it is. We want to tell our patients that things are going to be okay, which for 99.999% of people, that is absolutely correct. So knowing this, how Autumn presented, I did think about myself in the ER physician's shoes. Everything looks fine, but the ER physician back then had an intuition, a sense. Something wasn't quite right. And I think as a physician, that's something that you develop with many, many, many years of practical bedside encounters. And I think that's really what it takes to be a great physician, is to have that intuition. I can't name what this is, but something's not right. I'm going to keep this patient overnight. And that intuition really saved Autumn's life, because if the ER physician had not done that and said, look, all your labs look okay, we can't quite figure out what's going on, but we'll send you home, she may have, well, we know that she got worse, but she may have gotten worse and passed out and essentially died at home. So that intuition really saved her life, and it's something that I think all of us as physicians who treat patients really try and get that sense, get that skill.
Dr. Brown is the director of the Office of Emergency Care Research at NIH. Has written more than 30 peer-reviewed articles and 3 books, including Influenza, a 100-year hunt to cure the deadliest disease in history. It explores the complexity of the flu virus, beginning with the deadly global flu outbreak of 1918.
What about 1918? Describe for us what it was like, because this influenza outbreak, I mean, it almost brought society to its knees in many respects, didn't it?
Sure. So this is really what got me involved with writing the book, is this anniversary, this 100th anniversary of the 1918 epidemic. So just to paint the big picture, somewhere between 50 and 100 million people died worldwide from influenza from early 1918 through to the January and February of 1919. 50 to 100 million people. In the United States, somewhere around 600,000 people died. In today's numbers, that would be over 3 million deaths in the US alone from influenza. In Great Britain, 250,000 people. Again, in today's numbers, much, much higher than that. This epidemic spread to essentially every place on Earth. And I think one of the most chilling aspects of the influenza outbreak of 1918 was, of course, the realization that nobody knew what was killing them. They had no identification of what this bug was. People called it influenza, but they didn't know what it was, how it was transmitted. They had some ideas, but really modern medicine was really in its infancy even 100 years ago. And the disease would come on very, very quickly. It uncharacteristically targeted young, healthy adults. Most infectious diseases are worse, are more severe for people who are elderly or very young. But usually the people in the middle, the young, healthy adults, they're usually the most resilient to infectious diseases. This influenza virus of 1918, it seemed to have a target on this young adult population, and they were actually at higher risk than the typical populations. And so the disease of 1918, the influenza of 1918, killed young adults in far higher numbers than you would have suspected. And it decimated towns and villages, factories closed. Of course, it was it came at the tail end of the Great War of 1914-18, so the disease was transmitted at very, very high rates in the army camps that were both on the continental United States and in France and Europe. People were in very great proximity to each other, so the disease was coughed and sneezed over each other, and so the disease spread very rapidly among the soldiers and recruits of 1918. And as I said, when it was all said and done, somewhere in the region of 600,000 people in the US, 3 million in today's numbers, were dead, and they still didn't know what it was that had killed them. And there was no treatment. Back in those days, there were no antibiotics. And so if you came down with a complication of the flu, like pneumonia, it would kill you. And it has actually been suggested that it wasn't the flu itself that was causing all these casualties and fatalities, but actually what most people were dying of were the complications of flu, were these bacterial secondary infections in the lungs that all doctors could do was stand around and watch and wait. That was all that they could do. So you had this disease that was wiping out the unhealthy population, and people didn't know what it was called, and they had no cure for it. They had some suggestions, and we can perhaps talk about those. They had some things that they would try, but nothing that we would today consider to be anything like effective medication.
Initially, the flu may seem like a common cold. Symptoms include a runny nose, sneezing, and a sore throat. But a cold usually develops slowly, whereas the flu tends to hit suddenly.
One of the symptoms, obviously, with the flu is fever. Is that a good thing? I mean, should people be nervous about this? I mean, what do you tell the patients when they come to you? Oh my God, I've got this fever.
Yeah. So fever is the body's response to an infection. Most people who study the evolution of viruses and bacteria appreciate that the body's temperature is raised for a reason, and that probably we fight infections better when our body temperature goes up a little bit. That's why we have evolved to mount a fever. Fevers, though, make us feel very uncomfortable, and even though they may theoretically be good for us in terms of raising the body's temperature and the body being able to fight infection better at that higher temperature, even though that may be true, fevers feel pretty miserable. And so one of the things that we all do, whether we're at home or in the emergency department, is that we give medications to bring our fevers down. Now, usually that's fine. There is a theoretical, and I mentioned this in the book, there's a theoretical possibility that by reducing somebody's fever, you make them feel better quicker, and then they go out back into their social setting, and not quite cured of the flu, but feeling better enough to go downstairs and cough over their family members. And in that way, there's a theoretical possibility that you actually spread more of the virus by taking somebody's temperature away and allowing them to feel better and get back into society. It's a theoretical risk. I don't think any of my patients would be happy if I sat down with them and told them that there's a theoretical risk of doing this, and therefore I'm not going to treat your flu with a medication to take the fever away. So we all treat the flu with these medications, but it is important to remember that the body's response to infection with a fever is probably the right thing to have in terms of an evolutionary mechanism to fight infection.
In order to better understand the virus, researchers closely study flu samples, including preserved tissue from the deadly 1918 virus.
Here we are on the NIH campus, and the 1918 virus is here. But it might as well be in Fort Knox, the way you describe it. It's not easy to get at, is it?
That's right. It's actually in a padlock freezer in a building that is only accessible once you go through very high level of security, actually. You're not allowed cell phones or thumb drives. And I actually managed to see it. It was the closest that I got to 1918. It's in an isolation room, I should say. It's in an isolation room in this large freezer, and there is the 1918 virus, and it's quite a feeling actually to ponder that. There are a few places in the United States and a couple in the world that have the virus and that actually still do work on it. And here on the NIH, this is one of the campuses that does hold the virus, and they have a very, very active research program in influenza. Many, many millions of dollars a year are spent here on influenza.